Welcome to the Heart Rate Variability Podcast. Each week we talk about heart rate variability and how it can be used to improve your overall health and wellness. Please consider the information in this podcast for your informational use and not medical advice. Please see your medical provider to apply any of the strategies outlined in this episode. Heart Rate Variability Podcast is a production of Optimal LLC and Optimal HRV. Check us out at optimalhrv.com. Please enjoy the show. Welcome, friends, to the Heart Rate Variability Podcast. I am Matt Bennett. I am really excited for our guest today. Anna had written what I thought was an incredibly important article on allostatic loads. So I reached out. I know we just met a few minutes ago, so I am so excited, Anna, to have you on the episode to talk about some of the great research you did. You also sent me some of your past research as well, which I've been geeking out about since you sent that to me. So I know we have a lot to talk about. I'm excited to have you on the show. So welcome. As always, I love for our guests just to give a little bit of introduction to yourself and how you came across heart rate variability.
Okay, hello to everybody. Thanks so much for the invitation. Well, my name is Ana Lucia Miranda. I am from Colombia, South America. I am a medical doctor. I got my MD degree from University of Antioquia here in Colombia. And then I also had a master's degree in genetics. And then I moved to the United States where I did my PhD and postdoctoral training. I did my PhD at Johns Hopkins and my postdoctoral training at NIMH. Then I came back to Colombia and I have been working on the topic of the gut microbiota brain axis and its relationship with stress response. So during the last 10 years, I have been very interested on understanding the stress response in humans, and it's like because of that reason I came across to the HRV field.
Awesome. And I'm curious, how that where your research started, because one of the things I love about your article as well is sometimes when we think about the autonomic nervous system, there's not a whole lot of brain research in there. It's hard enough just to measure one complex system of the body. And so I'm curious about, how when you look at the brain, when you look at the autonomic nervous system, just, when you talk about stress and the stress response, I'm curious how both of those aspects of our nervous system frame your understanding of the stress response, and we can start talking about allostatic load as well.
Okay, well, the stress response involves like many steps. The first step is the exposure to stressors, right? And here it's very important to differentiate that we have two big kinds of stressors. One group is called like the biogenic stressors, which are usually substances or physical changes that will activate the stress response without any thinking or emotional involvement. But then there is another set of stressors which are called psychosocial stressors. And for that, it is very important the perception that you have of this event. So after you get this perception, is then also mixed with like memories and emotions, then there is an activation of different systems. And the first one is the activation of the autonomic nervous system. And as a result of that, then you get all these autonomic responses like increasing heart rate and also increase breathing speed and many other things like increase also like the muscle tension, because this is like a kind of the fight or flight response, right?
Yeah.
And then after that, you get also an activation of the HPA axis, which involves the secretion of cortisol. And these two systems, the sympathetic nervous system and then the production of cortisol, are kind of the main hormones that are involved in the stress response.
I love that. And the one of the words that they use, which wasn't fully new to me, but I like the sympath. I'm gotta make sure I say this right. Sympio sympiovagal.
Sympathetic, sympathetic
Yes,
vagal.
it looks so easy to say on paper, but I
Yeah.
love how you think about those two, because kind of that dance between the sympathetic, I think, and the vagal nerve, as you talk about utilizing heart rate variability to kind of measure allostatic load and other stressors.
Okay, so the sympathovagal quotient is a way to call the LF-HF ratio, which is one of the metrics that are used to measure HRV. So this ratio is a little bit controversial. It initially was thought to indicate just a very simple relationship between the vagus and the sympathetic activation. But then this was challenged with research, and right now it is not considered like simply like a relationship between the parasympathetic and the sympathetic nervous system. It also has other influences like hormonal influences, and it also is related to the baroreceptor activation. The heart also has a chemosensing receptor, so some hormones and other things like changes in circadian rhythms are influencing this ratio. In addition, like if you are sitting or if you are standing, or the time of the length of the recording and many other contextual factors are going to influence this ratio. However, like if you look at the literature, well, you can see like an increased ratio is related with psychiatric disorders like anxiety, depression, panic disorder. But if you look at, for example, very old people, and if you look at some longitudinal studies that were done in older people, you see that the risk of death or cardiovascular disorders was related with a low ratio. So you can see kind of a controversy there. If you look at metabolic disorder, an increased ratio is going to also be related to risk. So in summary, it's like in some population, you are going to find that low ratio is related to risk. And then in other group of people, like in the psychiatric disorders people, you're going to find like there is a higher ratio that is related to a risk of developing these disorders.
I love that. And I appreciated your article, because one of the things that I'm really struggling with now, somebody who reviews, I'd like to say every article published on HRV, though I'm assuming I'm missing a few here and there, is you'll see the LF-HF ratio without any disclaimers. And I really appreciate your article, because you just put the controversy on the table. And I would, if I were just a researcher from the outside and said, hey, Anna, I'm thinking about using the LF HF ratio, would you, from a research perspective, would you encourage me to not use it, use it in certain circumstances, depending on what I'm researching? I'm just curious, because I'd say over half the articles I review use the LF or HF ratio, but they don't give the great disclaimer that you did in your article. So this is a question more for Matt than maybe anybody else, but I'd love to hear, sort of maybe advice that you would give others having thought substantially about this.
Well, there are some papers that like explicitly say like do not use LFHF ratio because you don't know how it is originated. Like we don't know exactly what is the physiological origin of it. But then when I think about it, it's like, well, when I did my analysis, I found that it was this ratio what was associated to the allostatic load index. So I cannot say now like, okay, so even though it is associated, I'm not going to use it because someone else said that is not clear what is the origin of it. So, I mean, I think it's important to use it to be clear about the interpretation, and it's important to evaluate it in different contexts, like, you know, different population, different ages, sex, and then with all this research together, we might get like later a more clear view of what is going on with it. Like, I think it is informative because like, I don't think is I think is, even if it's controversial, what it in general is saying is that it point out to you that there are many factors involved in that ratio, and those many factors are the ones which are related to your phenotype, something that you are studying. So the fact that you don't know exactly what it is means that it's a complex metric that is putting together many different physiological factors. So to me, it is informative.
Yeah, and so as you looked at allostatic load, and I would love to get your definition of that. It's a term I know we've talked a lot about on our show. You know, one of the interesting, I think it was equally interesting to me as we talk about my obsession with the LF HF ratio, but what you found, how you measured it, and also what you didn't find. Because I think that was, you know, I would assume that as my allostatic load would increase, you would see certain HRV metrics decrease, and it wasn't necessarily, you know, what you found in the way that I think simplicitly I would assume you would. So why don't we start out with, you know, what is, you know, as you kind of gave us that definition of allostatic load, but you broke it down really different ways to assess it in the paper itself. So I'd love to sort of do a deep dive into some of that research and how you structured the measurement of allostatic load.
Okay, so allostatic load is a measure of the burden that chronic stress has on different tissues, right? And the allostatic load index was a measure that was proposed like long time ago. I think it was, well, I don't remember exactly the time, but I remember it was Seaman who proposed the first allostatic load index. And she measured many different biomarkers. And from that point to now, different researchers have tried different combinations of biomarkers, different methods to calculate the allostatic load index. But in 2023, McCrory, he reported a meta-analysis which put together many studies. Most of them were longitudinal studies. So this is very important information. And he came about, like, he created an allostatic index composed of 5 different biomarkers. So because of the very well done research that he did, we took that as a starting point. And from that 5 biomarkers, allostatic load index, we built 2 different alleles. We built one that was short, so it has all the markers that McCrory had, except one of them, which was resting heart rate. And then we built an additional allele called allele 7, which has all the markers that McCrory proposed. We eliminated heart rate, and we added the DHEAS, which is an endocrine marker, and added also blood pressure, diastolic and systolic blood pressure. So the other markers, in total, like the allele 7 is composed of the blood pressure, the DHEAS. It also has a immunological marker, which is the C-reactive protein. It has glycated hemoglobin. It has the HDL, which is a metabolic indicator, as well as the glycated hemoglobin. And and it also has an anthropometric measurement, which is the relationship between height and the waist circumference. So So basically, in summary, what we did was we took that Macroris allele and then we built like two different alleles and tested if they were related to different heart rate variability metrics. And the only one that was associated controlling for confounders was the LF-HR ratio.
And did that surprise you as much as it surprised me? Because I would assume we would see high frequency, RMSSD, SDNN. I would, my assumption would be as allostatic load increases, you would see a decrease in those metrics as well. So I'm curious, what was your surprise as great as mine with some of the results you were getting?
Well, no, I'm not really that surprised because a year ago, I published my first paper on this topic, and it was also the LF-HF ratio, which was related to brain connectivity and gut microbiota composition. So I think it is because of the population that we're using. We're only using men, and they are young. And I think this metric is like kind of collecting more information than the other metrics that, for example, are RMSSD, which only focus on vagal, like mostly vagal information. And the SDNN, well, it is a very well-recognized marker of cardiovascular disease risk, but these were young men, healthy. So I think I'm not that surprised with that. I was not very surprised with that.
And do you think with if different populations, do you think the population, I guess, if we looked at, I mean, just a randomized sample from society with different ages and health conditions and fitness levels and nutrition and sleep quality. Do you think that and again, I always give my guest the ability to speculate will never hold you to this speculation because obviously we need research to back it up eventually. But do you think it was due somewhat to the population, the specific population you looked at, that we didn't get some of these other metrics trending, how I guess I would expect them to with allostatic load?
Yes, I do think that it has to be with the characteristics of the population. Like if we take a sample, like a larger sample, very mixed up, well, I don't know. I think maybe the SDNN will show up more likely. But yes, I think this, as I told you at the beginning, when you look at the research with the LF-HF ratio, you see different results depending on the age, depending on the disorder. So if there is a lot of variability in a sample, I don't think the LF-HF ratio might show up.
Okay, gotcha. I just kind of wonder also any other surprises. I'd love to talk about some of the conclusions that you made along the way as well, and obviously for the audience, we'll put the link to the article here in the show notes to ensure everybody has access to it. But I would love to just like conclusions, surprises along the way that you might have had.
Yeah, well, I mean, well, something that is interesting to highlight is that in the index, we added the DHEAS, the endocrine marker. This hormone is very interesting because it is synthesized from cholesterol as well as cortisol is. So, and they have like an opposite relationship. When you have a high cortisol, you have this other DHEAS low. So usually they are even used together, like the cortisol DHEAS ratio, instead of one of them together, one of them separate. So I think to me it was very kind of surprising when I read McCrory's work and when we did the analysis, because I used to think that cortisol was the hormone that was going to tell us that someone has been chronically stressed. Find out that McCrory reported in his paper that cortisol was not one of the biomarkers that were included in the allostatic load index. And he even suggested in his paper that this other hormone, the DHEAS, should be the one that should be added to future indexes, because when they added just this hormone, all the analysis in their different indexes improved. So when I came to my data and analyzed my data, I didn't find like a clear relationship with cortisol and the HRV. But the DHAS did show like an important association. And I think that was the biggest surprise that I had during this research, because it's kind of a dogma to talk about cortisol and chronic stress. And then you look at this huge meta-analysis from McCrory, cortisol is not. I think it's not because, of course, it is a hormone that is involved in the stress response. However, cortisol has many different ways to be measured, like from hair, from urine, from blood, and it changes during the day. So it's very hard to get like homogeneous sampling. And I think that that makes very difficult to find an association across many different studies.
So I would love, your paper got me thinking. I haven't drawn any like epiphany level conclusions about it yet, but should we be thinking differently about allostatic load? Because I would, being a nerd about the autonomic nervous system, I would think the more stress you are, the more the load burns up, builds up, the more the vagal would withdraw, the more the sympathetic would start to influence. And we did see quite some of the things that I would assume, I think pretty educated as I am on a heart rate variability, I did see some of that. Is there a way that let's say the layperson on the street comes up, hey, and I know you're an expert on allostatic load, tell me what it means for me as an individual. Did this change how you would talk about that, or did it reaffirm what you already sort of knew? I'm just curious, because I had to kind of rethink some things as I went through the article, because it did not follow the way I was planning for it to, as far as some of the metrics.
Okay, well, I have been very interested on preventive medicine. So I think we should do a lot of education and try really hard with people to motivate them to do as much as they can to avoid getting sick. I think that's real medicine. So that's the reason I'm studying healthy volunteers. So what I think is important to notice here is like what this is saying is that if you measure these biomarkers and build this index, what you're gonna be able to measure is what is the risk you have to develop future diseases, right? Future disorders, physical or mental, because we know that allostatic load is related to like chronic disorders, and as well as HRV. HRV is also an indicator of risk.
Yeah.
So the reason we did an association we tested the association between the allostatic load that we built and the HRV metrics is because HRV metrics is recognized as a risk indicator. So if we test these two, what we will say is like if you have high allostatic load, you have an abnormal HRV metrics, and this is telling you that you're in risk of developing mental or physical disorders, or even you have an increased risk of die for any cause. So what this is saying is like with this kind of index, you can measure risk to get sick or die in the future for some disorder, right?
And I'd love to hear too your thoughts on chronic stress versus acute stress and allostatic, because you could have and correct me if my use of any terminology here is, I'll simplify it, but if I'm way off, is you could have a really bad day and have a high allostatic load. Like, obviously, don't have to experience trauma to get there, but if you just have a horrible day all the way around, your allostatic load is going to build up during that day. However, you could be in a dysfunctional relationship, you could be struggling with poverty, you could be struggling with a chronic illness, you could have more of a chronic day after day after day after day, burnout that I see in some people that really, you know, puts a burden on the autonomic nervous system. And I would love to get your thinking around allostatic load, acute versus chronic, and sort of how the research informs your thinking around that as well.
Okay, well, I think here it's important to kind of describe some different terminology. Like
Yeah.
allostasis is something that explains the ability that our body has to face different situations, right? So let's say it's like if you had some of these bands that you use for your hair, and then you just pull it like this. And then because you have allostasis, if you just stop pulling it outside, and then it will return to the normal shape, right? Without any problem.
Yeah.
That will be the way you will respond to an acute stressor,
I love that.
It's like you go back to the normal situation, and this is an allostatic response. But if you keep pulling and pulling and pulling, and you pull and stay there for a long time, then what will happen with many times that this is happening during your life is that you're going to build a load. That will be the allostatic load, right? So this means that the allostatic load implies that it's a chronic process. So you cannot say that you have allostatic load because of acute, acute stress, stress, or like in one situation. It has to be a cumulative effect.
Yeah.
So then, and after the allostatic load, you have the overload. You can have something that is called allostatic overload, and then at that point you're sick. You have your disorder as a consequence of the chronic stress, and after that, well, it's death. So I think that's like the sequence of the events.
I love that. I'm curious about, sort of, and maybe you're jumped on, and I know by the time I read your article, it's been several months since you've worked on it. So I'm curious, are you, or do you plan to do more work in this area? Your article just shines such a light on this for me. I'm surprised every once in a while when I read an article, but this one was really one of those ones that I was like, I had to think about and chew it around in my brain and see if anything positive came out of it. And this is why I've been looking forward to this. But I'm curious, where do you think the research around this can and should go, and just any thinking that you might have about how do we further really the biological understanding of allostatic load? So I continue to be dumbfounded by some of the findings and learn from how to shift how I talk about it due to research like yours. Like, are you going somewhere else with this in the future, or where would you like to see others go as well?
Yeah, so well, I would like to validate this Ali as a diagnostic tool for like a risk for risk to develop disorders, psychiatric or physical disorders. So I think this is the first step towards that validation. I was like one of the strategies is that we're gonna start using this Ali and collecting more information about patients that attend like to a neurological center. So and the other way is like we want to do a follow-up of to the people who participated in the research. So All these men who participated in this research, all these measurements were taken several years ago, and we would like to know how they are doing now.
Oh, that'd be awesome.
That's another way to like advance in the validation, because I think it is very important to give a tool to be able to avoid the development of these chronic disorders and to teach people how to stay healthy. And I think if they know how they are doing, they might kind of be more motivated to reduce their allostatic load, or if it's low, like to avoid that it gets high. So yeah.
I love that. So it's sort of, I would love to also ask the question of, and I'm sure you thought about this with the research as well, the best way to measure, or to get HRV data when we're looking at allostatic load. I know, you can wear rings and watches and straps, that can measure anywhere from 3 to 5 minutes to 24/7 monitoring. And I would love whether you learned anything from this, the research you've done, whether you have any thoughts about future research, whereas heart rate variability doesn't necessarily have to be measured in a laboratory setting, even though it's probably way more accurate when we can control some of those variables. I'm
Mhm.
curious if there's anything about how we collect, HRV data that could inform or you would suggest inform others future research around allostatic load.
Well, I used for my research, I used these 24 hours recording because we had a specialized cardiovascular disorder center here, and we
Nice.
worked with them. They at that point we had they just had like a new software, the custom software, which is from Germany, and it gives like a very nice and detailed report of everything that happens during those 24 hours recording. So, I mean, if I think the selection of which recording method are you going to use depends on your research question. Like if you want to collect naturalistic information, like what you are doing during 24 hours,
Yeah.
then it gives you like more information. And what it even tells you, this software gives you information during the day, during the night, or
Yep.
during the whole day. So you have like many different ways to analyze it. When you do it in the lab and it's just 5 minutes, I think I know there is research that shows that there are almost perfect correlation between short recordings and some
Mhm.
long-term recordings. But I think it's like, yeah, it will depend on what is your question. For us, we thought like it was better to use the 24 hours. And I
Mhm.
think I'm not very like familiar with the different devices, but I've seen very little devices that can be used during the day. Because the ones that we used like were really high, like very big kind of recorders,
Yeah.
and some people feel very uncomfortable with them. But I recently saw, I think it was in the Harvard Institute, there was a very little machine, and
Mhm.
yes, so it will depend on different aspects of your question, and also the possibility to get the recorders and the way people feel wearing these big recorders or smaller recorders.
Yeah. Yeah. So I'm curious, if you were to look into the future around this topic, well, again, pure speculation, so nobody's going to hold you accountable for this. What do you think, especially again, bringing in, you connecting the brain so well into this research as well. We talked about maybe it being predictive of risk factors, those sort of things. As our technology, as AI improves, where do you think, and I'll throw this question out more generally than just allostatic load. Where do you think the opportunities lie, knowing that stress has so much impact on our overall health, to really
Mhm.
learn more, moving forward? What would be if you could wave a magic wand and get unlimited funding and time? Where do you think that unlimited magical grant that would hit your desk? what would you like to spend a couple years just trying to figure out to understand us as humans and our stress response better?
Well, this is an interesting question. So, I mean, I am a neuroscientist. I have always thought, or maybe I used to think that the brain was kind of the most important place in the body that will control everything.
Mhm.
But during all these years doing research about the stress response, I now know that we have like at least three very big and important brains. We have the central nervous system, we have our heart, and we have the gut.
Mhm.
So I think it would be, for me, very interesting to study how visceral information, particularly the gut information and the heart information, is influencing on like the brain function.
Yeah.
And why I think this is important. Like, let's say, for example, if we focus on the interaction between the heart and the brain, um, like to me, it's amazing that when we use biofeedback, because I use biofeedback, HRT biofeedback, I can modulate my brain response.
Yeah.
And this is very interesting because I used to do neurofeedback to patients with very sophisticated equipment, and I also do neuromodulation with audiovisual entrainment and cranial electrical stimulation, and have to put on these earphones and your lights and everything. But it's
Yeah.
complicated to do all that, like when someone tells me, "Can you help me with sleep?" I say, like, I wish I could give you my neuromodulator and you can do it yourself, but you
Yeah.
cannot take it with you. So what I'm doing now is, you need to breathe, and
Yeah.
this optimization of the HRV through breathing, I think, is very, very useful. So from like it is, I think it's very important to keep understanding how the heart modulates the brain function, and develop like different protocols to kind of influence different areas of the brain. And regarding the gut, what I would like to know is how the gut communicate with the heart, because I have, like with my previous research, kind of, there were some hypotheses that the heart and the gut were communicating. And here there's like a big gap in research, like
Yeah.
how is it the gut communicates with the heart, and then the heart takes this information to the
Mm.
brain. Like the
Yeah.
gut can communicate directly to the brain, but it might also modulate the heart. And that there is a big gap on that connection. So that's something I would like to investigate too.
Yeah, I would love that. That's, your work with the microbiome is just as fascinating as the allostatic load article. And I think, we've talked at least, I think a lot more about, I mean, I think we try to separate everything. So it's like, oh, your second brain is in your gut. Well, I always like to say it's all one integrated system, one way or the other. We can break it up because it's easier to understand. And I really think we've thought a lot about, at least nerds like me, have thought a lot about like, diet and nutrition and inflammation and leaky gut syndrome and sort of how the brain and gut interact and all the chemicals the gut releases. It's astounding stuff, and I love what you said because you're bringing the heart into that as well, which you don't hear. I don't hear a lot in the thinking of this. It's like we got the brain, we got the second brain, and I love how you're thinking about bringing the heart into that equation as well. And I love,
Yes.
I mean, just what, and you mentioned HRV biofeedback, and just, I mean, one of the best documented, uses of HRV biofeedback is for irritable bowel syndrome. So, there's some really cool stuff, going on there, and again, I think to bring three complex systems, or more together, because you got the barrier reflex in there and everything as well, is a really, I think, as you mentioned, a rich opportunity for future learning as well.
Yes, yes.
And I've got to learn how to pronounce rumen o cock. How in the
Ruminococcacea. We can call it Rumi. Rumi.
Okay, Rumi, I thank you for that because I tried to pronounce that for about 5 minutes and then I'm like, I don't think I'll ever get there. So
Yes.
yes, I would love to dig into that more in maybe a future episode because I think it's we're getting there with understanding the importance of the gut and how the stress response hits the gut as well. And as you mentioned, we got a lot more room to grow with that as well.
Yes, we have.
Well, and I appreciate your papers so much. I've learned so much, and a good paper, I think, well, in my opinion, a good paper teaches you something. A really good paper or a great paper teaches you something and then makes you think differently about things. And your paper, I was like, I'm an expert on allostatic load, and then after reading your paper, I realized maybe not. Maybe not, and maybe everybody that thinks they're an expert on this, that there are so many open questions there that I'm excited to keep in touch with you and your research to learn what you discover. And yeah, again, I just want to thank you so much for your work and joining us today.
Thanks so much for the invitation.
Absolutely. As always, you can find show notes. We'll put links to Anna's work and the articles in the show notes. And as always, thank you for joining us. You can find more information at optimalhrv.com, and we'll see you soon. Thank you so much.